She's considered one of the big stars of the radiology in Israel, and she's a very bright star. So thank you so much.
Elegant and sexy accent you have. So I'm going to speak about vascular malformations in pediatric patients, and this is not something that we see on the everyday life, I think most of us, but I still think there's a little bit of interest, and I will try to do it a little bit more, softly. Microphone. בסדר? I'll talk about aneurysms and then a little bit about AV malformations in the pediatric group. Aneurysms in children. So aneurysms are not congenital disease as far as being present in childhood. If you're going to scan a fetus or a child that was born, you're not going to see aneurysms 100%. But they reflect some various types of structural or functional diseases, and the potential is there even when we are born. And as a rule, and I won't say this sentence about children and adults, but childhood aneurysms are different from adult aneurysms, and you can see here this example of a 6-year-old boy that was presented with a left third nerve palsy. If it was an adult, so all the residents here would do a CTA on the ER just to look for pecom aneurysm or brain infarct or something like that, and this is a boy, and if you look at this angiogram, this is injection to the right vertebral artery. You see that he's got this fusiform, bizarre dissecting PCA aneurysm pressing his third left nerve. As a rule, as a whole, they have, pediatric, the kids, they have the same aneurysm or shape as the adults have, the baryaneurysm, the giant, the fusiform, and the dissection. So I'm just going to go and remind all of us, those are 3 examples of baryaneurysms. You see the basilar tip aneurysm here. You can see an ACOM, this is the anterior communicating artery. This is A1, A2. This is like looking from the behind on the patient. This is an ACOM aneurysm, and this is a lateral view of an angiogram. This is the ophthalmic artery, and this is a large pecom aneurysm. So those are the usual varisecular aneurysms. Giant aneurysm, as a rule, it's when the aneurysm is larger than 2.5 centimeters, and kids can have them. This is an example of Hydrovenous left carotid aneurysm. This is another giant aneurysm causing mainly pressure on the brainstem. Fusiform aneurysm, and to be honest, this is an MRA of an adult. This is a fusiform aneurysm of the basilar artery. In the adults, it's usually a part of atherosclerotic disease. In kids, it's different, and we'll get to that. And dissecting aneurysms, you see here a very nice example. This is axial P1 fat set. You see this hyperintense signal in the wall of the carotid that represents a dissecting aneurysm. This is MRA of this patient. You see here the narrowing of the left carotid. You see this hyperintense lesion. This is the dissecting aneurysm. And if you look carefully, you see that he's got the same lesion on the other side. This is the narrowing of the carotid from the dissection, and this is the dissecting aneurysm in the wall. This is another example of very massive subarachnoid hemorrhage, and if you look at the angiogram, this is lateral view, injection to the vertebral artery. You see those areas of narrowing. You see the dissection is going into the pica artery, and there's a tiny aneurysm here that caused the hemorrhage. So, childhood aneurysms are different from the adult aneurysms, and in what? First, who's having them? In the adults, the aneurysm is more of a female disease. In the kids, it's a little bit more towards male disease. You see it's 3 to 1. The location of the aneurysms is totally different. We have much more posterior circulation aneurysm. About 30% of them are going to be on the posterior cerebral artery, not PCOM. And a lot of them are going to be in the carotid bifurcation, intracranial carotid bifurcation, in comparison to the adult, which you know is ACOM, PCOM, and then Vascular and MCA. Quite a lot of them are going to be large or giant, about 20%, and they're going to have less multiple aneurysm. In the adult population, about 20% of the people will have multiple aneurysms. If you see multiple aneurysm in the kids, you have to think of infectious. It's rare. The main cause in kids is going to be traumatic dissection and infection in comparison to the adult, which the most are going to be saccular buried aneurysm. And one of the most interesting things is if you're going to follow those kids, some of them will have a spontaneous thrombosis and healing of the aneurysms without treatment. Okay, just looking at the the age, you see it's 2 years, 2.5, it's getting older, and the reasons for the aneurysm. So you see as the kid's getting older, he's becoming an adult, so he's got more saccular aneurysm, like very aneurysm, but young kids have more dissections and a little bit more infectious and trauma in comparison to the adults. So every time you see an aneurysm in a kid, you have to think about an underlying disease. And for us as radiologists, you have to look for disease in the other vessels and the neck vessels and the cardiac. To look at it. Okay, so associated diseases. About 21% of arterial aneurysm in kids, they're going to have aortic coarctation. Polycystic kidney disease, we know that from the adult, about 7% of them are going to have aneurysms. Also in the pediatric population, there's always the question about who should we screen. We don't really have answers for that. Other diseases are like fibromuscular dysplasia, Marfan syndrome, all collagen vascular disease. Most of them will have extracranial aneurysm in comparison to intracranial. Tuberosclerosis, NF1, we know that they have a lot of vascular presentations. Hereditary hemorrhagic telangiectasia is more famous, let's say, with micro-AVNs and AVNs and AV fistula, but still they can also have aneurysms, and then the Moya-Moya disease. We know that the tiny PL vessels can have tiny aneurysms that are causing problems. This is just a group of patients from Toronto where I did my fellowship, and they have a group of 33 patients with 37 aneurysm. You see that the male-female ratio here is not like in the literature, and the age is very wide, and the follow-up was for a long time. The presentation of the kids in this group was a third of them with neurologic deficits, third with headaches, and only third with subarachnoid hemorrhage. If you look at the literature, you're going to see that still, like in the adults, most of the kids are going to present about 70% with a subarachnoid hemorrhage. And then some of them can present with infarction, seizures, which is very interesting, intracerebral, intraaxial brain hemorrhage, loss of consciousness, and neck stiffness, pain. They're sick sometimes, and we'll see examples. So now we look at the subgroups. So traumatic aneurysms are about 15% of pediatric aneurysms, and this is a lot. Most of them are going to happen in what we call the anterior complex along the ACA and the falx, probably because of trauma against the bone or the fat. Some are going to happen in the skull base where the carotid enters the brain, and then we have the diffuse cortical, and I'm going to show you an example. The interesting thing is most of them are not going to present with the trauma. The patient is going to have a trauma, is going to go home and come back weeks and sometimes even months after the event with the aneurysm. So this is an example of a 7-month-year-old, I can say it in another way, 7-month-old baby with a sudden loss of consciousness, and 2 weeks after, a story of a bump in the head, and he's got this huge hemorrhage in the ventricular system, probably in the corpus callosum and along the falx. And this is his angiogram. This is injection to the right internal carotid artery. You see a normal MCA, this is the A1 and the A2, and you see this bizarre lobulated kind of scary aneurysm that is post-traumatic. You see it on the oblique view here. And this is after treatment. He was coiled. If you look very carefully, you see the coils here in the aneurysm. And if you notice, you see that the ACA is gone. And if we meant to do it, or if we didn't, usually traumatic aneurysms will also involve the vessel, and usually the vessel will be sacrificed also. And if you look at the angiogram 6 months later, you see beautiful, the PL collateral that this boy gets from the MCA. You see it's darker because it's slower, and it fills the ACA branches all the way towards the apical complex, and the boy was fine. This is another example of a boy about 7 years that had a head trauma. He had this small frontal hematoma and a fracture in the frontal bone, and he went home and he was fine. And then because of continuous headaches, he had an MRI 5 months after the event, and if you look carefully, you see that he's got this encephalomalacia in his frontal lobes, but then he's got this small black lesion on the T2 enhancing, and if you suspect that, then you do a CTA, you see this small post-traumatic aneurysm. You see just here on the base of the skull where the fracture was, and interestingly, this is his angiogram. This is injection to the left carotid, and you don't see the aneurysm because the vessel is so small and it takes time for the aneurysm to feel, and then you see it here. He was treated endovascularly with injection of glue that was very difficult to get to the aneurysm, and it was excluded. Okay, infectious aneurysms, again, with the adults, it's between 1 to 9% of the aneurysms. In kids, it's much more, it's about 15 or even more of the aneurysms. The most common cause is staph, although we used to call them mycotic, but usually it's staph, but then it's strep and gram-negative and also mycotic aneurysms. We know that HIV patients have a lot of vascular issues with vasculitis and aneurysms and a lot of changes in their vessels. And the cause is probably coming or from the lumen with septicemia or from the surrounding. We can see cavernous sinus aneurysms in kids with a very severe sphenoid infection, causing secondary damage to the carotid and cavernous aneurysms. This is like an amazing example of a 14-year-old boy with AIDS that had a right hemiplegia, sudden right hemiplegia, and you see it's almost difficult to understand. This is injection to the right to the carotid. This is almost a lateral image, and you can see that all the complex of supraclavicular carotid, the bifurcation, the ACA and the MCA is not normal. Part of it is aneurysmal dilatation, part of it is just damaged vessel. You can see this is like an AP view. This is the two aneurysms and the damaged MCA. What was interesting about him, and we'll get to that he was treated, you know, with antibiotics and with HIV medications for some time, and that was his follow-up. And there was some remodeling of the blood vessel. We didn't do anything. We just watched him. And then to the usual saccular-berry aneurysm. I mean, it's not the most of the pediatric, but it's still about 30–40% of the aneurysms. And in the adult, it's happening in the bifurcation of the vessels, most of them in the circle of Willis. We all believe that there is some hemodynamic issue in the creation of those aneurysms, probably because of neural and systemic factors, which are probably different in kids in comparison to adults with hypertension and smoking and all that. So example of a 20-year-old girl with a subarachnoid hemorrhage, and she had this carotid bifurcation aneurysm. She was treated with coiling. You can see the coiling mass in the aneurysm, and this is the angiogram post-procedure. You see the aneurysm and gone. This is the same as in the adults. Dissecting aneurysm, I think, is one of the most interesting aspects of this thing of aneurysm. It's much more common in the adults, and it's interesting the location. Most of them are going to be in the posterior circulation along the PCA. Some of them are going to be in the M1 segment and the supraclinoid carotid. And the angiography appearances, you know, you have to understand its dissection. Usually you can see that the vessel is not normal. It's not just the aneurysm, it's the vessel is narrow or dilated. And sometimes we just see these plastic arteries that we believe is a secondary to dissection. This is a bit bizarre example of a 7-month-old boy with this weird looking, if you look at it, it's more a fusiform, maybe dissecting aneurysm. And it was interesting because he had an intracerebral hemorrhage with this almost extradural aneurysm. It was a bit years ago, and he was treated with what we call sacrifice of the carotid. You see this is MRA, and you see that the carotid is gone. There is no normal signal going in the cavernous sinus from the carotid, and it's getting supplied through the circle of Willis. This is a case just from a few weeks ago in our hospital. A 4-year-old boy was presented to another system with severe headache, vomiting like an event, but somehow he was, they thought he was sick, and for a few weeks he was just complaining of headaches and he was losing weight, no vomiting anymore. And at some point he got an MRI that showed this huge, large, hypo-intense black cisterna lesion, which to my opinion is a signal void causing major pressure on the midbrain. This is the time of flight, or the MRA that was done, and it's not filled so obviously, but it's not perfect, those sequences that we have. And I think this is the most interesting. This is T1 without contrast, so you can see this hyper-intense part, which is probably the partially thrombosed part of the aneurysm, and then you check contrast, so the partially thrombosed is not enhancing, and this is the enhancing part of the aneurysm. And to my opinion, this is a PCA dissecting aneurysm in a kid. This is the disease, and this is the angiogram. You inject the left vertebral artery. You see the normal right PCA, and this is the PCA on the left side. You see how it changes its caliber. It becomes more narrow, and you just see this huge thing filled with contrast, and there is still enhancement and filling of the PCA distally. This is just during the procedure, we were doing a balloon test occlusion. It doesn't matter so much, but you can see how the wire just falls into the aneurysm. There's no neck, it just opens into the thing. The whole vessel is dissected and sick. And this is why after you treat this patient with coil, you lose the PCA, because the PCA is disease. It can't hold this thing by itself. You see that there's no enhancement here on the PCA from the vertebral, but he got PL supply from the carotid, and he was fine with no visual deficits. Treatment. So it has this nice sentence about multidisciplinary team decision, especially with a neurosurgeon, and especially because we don't see so many cases, and we all need help and ideas. Those lines are concerning the group from Toronto, so you see that there's a lot of conservative treatment here, which is interesting. Not too many endovascular. I think today, if we look at the experience in Israel, and most of the patients will get endovascular treatment. But how can we treat aneurysms conservatively? It's really uncomfortable. Sometimes we just wait for the treatment, and as I told you before, we see that they got spontaneous thrombosis and resolution, which is, wow, this is great. This is the best for you. And sometimes they have fusiform dissecting aneurysm, no hemorrhage, and it's very difficult to treat fusiform aneurysm. And you just follow them and you hope that it's going to be fine. Sometimes it's just too dangerous. You can sacrifice the vessels, and people, as a rule, don't like to put stents in the pediatric population. You don't want to put them in aspirin for life. And then there's the infectious group, which if the aneurysm didn't bled, usually we treat them with antibiotics and, the treatment for the thing that caused the aneurysm. Surgery is clipping and occlusion. I'm not a neurosurgeon, so I'm not going to talk about that. And then the endovascular treatment is basically like in the adults. Those are the tools that we have. It's coiling. We can occlude the vessel if it's a giant aneurysm, or we can inject glue or onyx. A few examples. This is a kid with a right internal carotid injection. This is an aneurysm, and you can see it in another angle. And then this is post-coiling. You see the aneurysm is gone. This is another case. It's a 13-month-old girl, and she was just sick. Like kids. She was sick. She had fever. She was a little bit restless, and she was in the hospital, and they did everything for her in the pediatric department, and then they decided to do LP because maybe she's got some infectious disease of the brain, and they got blood on the LP, and then they did a CT. And then they saw the blood in the ventricles, a little bit of hydrocephalus, and this is the CTA, and now you all know this is a dissecting PCA aneurysm. Again, you see a little bit of thrombosed aneurysm, probably part of it is blood outside. You see this in the ventricle, and this is her angiogram, left vertebral injection. This is the aneurysm, and this is the aneurysm in the more enlarged. You see that the catheter is coming almost to the aneurysm, and then we put some coils there. This is coils, and the aneurysm is gone. And this is her follow-up. The thing is getting smaller, and she's... Okay. A few words about pediatric cerebral arteriovenous shunts. And this is not about teaching you about the shunts. This is just giving you a little bit of the feeling. People try to make this, a lot of vascular diseases and try to put them into groups. So we have the arteriovenous shunts. Okay, this is any disease that you have a straight connection between artery and vein is arteriovenous shunt. So we have the vein of Galen malformation, we have dural shunts, and we have the PLAVM. I don't know if someone was here in my next lecture. So this is the usual adult type AVM. If we're going to look at vascular malformations, so we have cavernomas. Some of us believe that AVMs are venous diseases. And then in the pediatric population, we have what we call proliferative disease, which hemangioma is one of them, but hemangioma is not a vascular malformation. This is tumor, but it's still a proliferative vascular disease. And then we have the moya-moya and the face syndrome, which is a syndrome that has, hemangiomas in the head and neck, and then cardiac and vascular malformations in the brain. Those are three different patients, okay, with three different CTAs that are trying to show you the different types of vascular malformations that we have in the pediatrics, more in the pediatrics, a little bit less in the adults, okay? So remember that. And those are the spaces that the malformations can happen. It can happen in the epidural or subdural space. It can happen in the subarachnoid space, or it can happen in the subpial, which is basically the intraaxial lesion. And those are the lesions. Those are the dural AV shunts, the same as we see in the adults, or the epidural AV shunts. This is like the vein of Galen malformation, and this is like the PLAVM, usual AVM that we see in kids, in older kids, and in the adults. So again, to the picture. So this is going to be a dural AV shunt, and it occupies basically the dural sinuses, and this is why sometimes dural shunts are difficult to see, because it's just all happening in the dural sinuses. In the pediatric population, it's usually large. You can't miss them. This is the vein of Galen malformation, which is more obvious to everyone. This is just the usual PLAVM. It's an intraaxial or almost intraaxial lesion, and you can almost always see the sinus. Just according to the age, so we have more vein of Galen malformation as the kid is younger, in utero, the neonates, and as the children go older, they become like adults with more PL malformations and cavernomas. And there's another rule. As younger as the kid is, it's going to be more fistula, a direct connection between artery and vein. And as they go older, it's more a nidal type of malformation. And the clinical manifestations of all the AV shunts. There's a rule. Kids with an AV shunt, whatever the shunt is, they're going to, the most obvious thing we learn. In med school is the cardiac insufficiency and the chronic heart failure and the heart congestion, as you see in this X-ray, which I hardly know how to look at. And then secondarily, they get renal failure and hepatic failure and coagulation disorders just secondary to their cardiac damage. Another interesting thing, to my opinion, is on the issue of hydrovenous, and we spoke about the CSF today. That because of the high pressure in the venous system, they get issues of CSF drainage. And altogether, it's causing a major problem in those kids. And they get macropania, they get enlargement of the ventricles. Sometimes it's hydrocephalus with enlargement of ICP. Because of all this enlargement in the cranium of fluid and ventricles, they have tonsillar prolapse. And then we get to the syndrome that's known as the melting brain syndrome, and I'm going to show you that later. If we look differently on their, again, systemic or the symptoms they have the systemic symptom. That means like the cardiac failure. Hydrodynamic means the issues of CSF and venous in the brain, seizures, hemorrhage, and neurologic deficit. And you see how it changes from the vein of Galen malformation, which is a huge shunt that takes all the blood from the body, in comparison to the PLAVM, which is a more intraaxial brain lesion, like a tumor, let's say. This is a very pronounced example. It was a 3 days old boy that was transferred to our hospital because, they're suspicious of cardiac failure and probably an intracranial vascular malformation, which everyone thought was going to be the vein of Galen. An MRI was done to him, and I'm sure all of you can see that there's like enormous signal voids here, a lot of blood vessels in the center of the head, and then there's almost nothing. This is like fluid all over the place. And now you can look at all the sequences. This is T1, and you see there's a little bit of hyperintense, so there are areas of blood here and thrombosis hemorrhage and thrombosis probably, and there is some enhancement here probably because of some kind of ischemia. And then, is that me? And then this is what we call melting brain syndrome. And this is a very serious and important issue for us. The melting brain syndrome is a secondary, or this is the end result of a very difficult hydrovenous dysfunction in those very young fetal vein of Galen malformation. This is rapid destruction of the brain parenchyma, basically the white matter because of high pressure in the medullary vein, and it's causing destruction of the white matter and enlargement of the ventricles. Usually there's no rise in the ICP, it's just everything is gone, it just disappears. You can never see it in the adult population. Calcification is one of the signs of it in a more chronic, slowly, less severe situation. And why is that important? Because sometimes people, like this 3-year-old, this is an amazing example, send kids for treatment, and if you can diagnose that they're starting to have this melting brain syndrome, we think it's like apoptosis. This is something that gets started, it's not going to stop, and this is a very bad prognostic sign. So calcification, if you see those white matter calcifications surrounding the ventricles in kids with vascular malformations, especially vein of Galen, this is a bad sign. You're not going to help them so much. A few words about vein of Galen. We know that Rebaud described in 1989 that this is not really the vein of Galen. This is the median vein of the prosencephalon. This is an embryonic vein. Those kids don't have a normal vein of Galen. And this is in comparison to the vein of Galen aneurysmal dilatation, which is another disease that has a large vein of Galen. But those are just the usual cerebral AVMs, Vernian AVMs, tectal AVMs, or any AV shunt that drains into a normal enlarged vein of Galen. This is not vein of Galen aneurysmal malformation. This is a fetal embryonic disease, and those patients has no vein of Galen, and they usually look like that. This is the median vein of the prosencephalon. They usually have, you see, those are the choroidal arteries, the anterior choroidal and the posterior choroidal arteries draining into the vein of the median vein. And some of them have what we call the limbic arch. This is again a fetal anatomy of supply of blood. This is part of it is the choroidal arteries, the ACA, and the posterior circulation, and it all drains into this diseased vein. They don't have a straight sinus. All the kids with the vein of Galen aneurysmal malformation. And sometimes they drain into the superior sagittal sinus. So this is just a crazy example of that. And we have two types, the choroidal and the neural type. And just a few words about them. The choroidal is the much more common. It's about 90% of vein of Galen. And what you see is a lot of choroidal arteries, and they create this network of vessels draining into this fetal large vein. It's usually the very young kids, and they have very bad clinical scores. In comparison to what we call the neural type, which is usually a single connection between arteries and the vein. Sometimes they have multiple. It's like a dural fistula, and it's in the wall of the vein. It's usually a little bit older kids, and they're a better tolerated. So this is an example of a choroidal type. You see this network of choroidal vessels going into the median vein of the prosencephalon. This is just to show you the craziness of the treatment, and they have special centers to do it. You get the catheter, and you just try to occlude another vessel and another vessel and another vessel, and the kids, end up with those images. This is just an example of a 4.5-month girl. This is her MRI. You see this large vein. You see here a little bit of the choroidal vessels, and then this is the treatment. You see the catheter here. You see the large vein. And then this is post-treatment, and you see even that the vein disappeared. This is a very nice result. Don't always get that. And this is the kid 1 year later. I'm almost at the end. A little bit about dural AV shunts, and again, this is about the pediatric population, not about the adults. We have 3 kinds of dural AV shunts in the pediatric population. The most severe and the most earlier to happen, like the fetal one, is the dural sinus malformation, the DSM. The shunt is secondary to a malformed sinus. Those kids have huge sinuses, like, and you can't miss that on the fetal due to fetuses. And this is another high flow shunt. The other one is the infantile dural AV shunt. It's usually multifocal shunts. The sinus, basically, we think it was normal, but it's large now. And they have secondary jugular valve occlusions. This is something we see also in a lot of dural shunts, but this is very, it happens a lot in this type. And the third type is the adult type, like the dural fistula, you know, in the adult, in the cavernous sinus and the sigmoid sinus. And this will happen in the more adult kids. This is one example of a boy with his head circumference is getting bigger, and this is his angiogram. This is injection to the left occipital artery, and you just see this huge and large sinus that is being opacified. This is another boy. If you look carefully, you see those veins trying to drain the brain outside into towards the face, and on his angiogram, you see this vessel draining into this huge dural system. And again, the difficulty of the treatment, we bring the catheters and we just go to every channel. And in this case, coils were put. And this is, you see those images of the kids. There are a lot of coils in every vessel, and there's a little bit of glue here, and trying to improve their prognosis. That's all. Thank you.
Thank you so much. Again, the lesson of teaching. Even if you're not a neuroradiologist, I will look at this lecture again just to learn how to teach.